Hello and welcome to this learning module. Today we're going to discuss the EMS response to emergencies involving high altitude and water. This video is intended to supplement any readings or coursework assigned by your instructor. Upon successful completion of this learning module, students will be better able to define drowning and list the care for a drowning victim, discuss the 3 types of diving emergencies and list care for a victim who's experienced an emergency while diving, and assess and manage a patient suffering from a dysbarism or high altitude emergency. The commonly agreed upon definition for drowning is the process of experiencing respiratory impairment due to immersion or submersion in liquid. In this definition, immersion refers to a situation where the airway is above water and water splashes over the face, and submersion refers to a situation where the airway is underwater. Outcomes of a drowning include one of the following. Number 1, non-fatal drowning without morbidity. Number 2, non-fatal drowning with morbidity. Or number 3, fatal drowning. Drowning victims will struggle to try to keep their airway clear, and as they become increasingly fatigued, they will submerge and attempt to hold their breath. Water is inhaled and aspirated into the lungs, which stimulates the body's cough reflex. If the person is not rescued by this point, water continues to aspirate into the lungs, and hypoxemia will lead to loss of consciousness, apnea, and subsequent cardiac arrest. It's widely recognized that healthcare providers should not use the modifiers near, wet, dry, saltwater, freshwater, or secondary in association with drowning. Research has determined that these modifiers are not valid because the final pathway is hypoxemia and eventual cardiopulmonary arrest. When arriving on scene to a water rescue, where the victim is in the water, responders should remove any turnout gear they may be wearing. Anyone working in or around water should don a personal flotation device or PFD. The typical steps of a water rescue include reach, throw, row, only then go. Number 1, reach out to the patient with an object like a rescue hook, boat paddle, or tree branch. Number 2, throw the victim a rope, life preserver, buoy, or other floatable object that is available. Number 3, row a boat out to the patient if one is available and trained to do so. And number 4, go into the water only when trained to do so. Here we see the 5 links in the drowning chain of survival that was released back in 2014. Prevention of drowning, recognizing a swimmer in distress and calling for help, and providing a means to keep the patient from submersion are the first 3 links in this chain. Removal from water and provision of emergency care are the last 2 links. Once the patient is removed and able to be evaluated, a rapid primary assessment, including assessment and management of ABC, should be completed. Water can be removed from the airway with suction. If needed, rescue breathing and/or CPR should be initiated. The patient should be treated for shock by keeping them supine, administering supplemental oxygen, removing wet clothing, and keeping them warm. Abdominal thrusts and/or back blows are not recommended treatment for these patients. While rare, spinal cord injury may happen in some submersion incidents. Consider providing spinal precautions in the following instances. Number 1, the submersion happened after a diving mishap or a fall from a significant height. Number 2, the patient is conscious and reports focal neurologic deficits, including weakness, paralysis, and/or numbness in the extremities. And number 3, the patient has an altered mental status coupled with witnesses who provide a description of a mechanism of injury indicative of a spinal injury. Stabilization of a suspected spinal injury in the water requires special training and practice. In most instances, spinal stabilization may not be initiated until the victim is out of the water. When a victim is submerged in cold water, the resulting hypothermia can protect vital organs from the lack of oxygen. The mammalian diving reflex is activated when our faces hit cold water, which causes a decrease in the body's metabolic rate. This reflex functions most strongly in pediatric patients. As a result, the patient may be successfully resuscitated even after a prolonged submersion. Both the Wilderness Medical Society and the American Heart Association, or AHA, recommends limiting in-water rescue breathing to rescuers who are appropriately trained to perform the skill safely and effectively in an aquatic environment. Otherwise, the patient should be rapidly removed from the water and rescue breathing can be initiated at that time. For obvious reasons, chest compression should not be attempted in the water. Current AHA recommendations regarding resuscitation after drowning include initiation of CPR with rescue breaths after removal from the water and prior to AED application. Based on multiple studies, the AHA also recommends that trained rescuers should provide rescue breaths by the first means available for individuals in cardiac arrest post-drowning to avoid any delay in ventilation. In the image here, a provider from the U.S. Coast Guard performed CPR on a drowned child. This provider successfully resuscitated the child while en route to the pier. So let's switch gears a little, and we're going to talk now about scuba diving emergencies. Emergencies can happen during any of the three phases of a dive: descent, at the bottom, and ascent. Dysbarism is a medical term for injuries that happen when the body is exposed to changes in pressure too quickly for it to adapt safely. These injuries can happen during underwater diving or during altitude changes. Descent emergencies happen because the pressure increases as the person dives deeper in the water. Areas of the body commonly affected by descent emergencies include the lungs, sinus cavities, the middle ear, and the teeth. These areas of the body may not adjust well to the external pressure, which results in severe pain. The pain usually requires the diver to return to the surface to equalize the pressure. While rare, problems at the bottom of the dive include inadequate mixing of oxygen and carbon dioxide and accidental feeding of carbon monoxide into the breathing apparatus. Both are caused by faulty connections in the diving gear. Depletion of breathing air can be an issue as well. Ascent emergencies happen if the diver ascends too quickly, which can cause an air embolism and decompression sickness. A common and dangerous scuba diving emergency is development of an arterial gas or air embolism. This happens when a diver holds their breath during a rapid ascent. The air inside the lungs expands too rapidly, causing a rupture of the alveoli, resulting in air entering the pleural space and causing a collapsed lung, air in the mediastinal area of the chest, and air bubbles entering the bloodstream. Pneumothorax and pneumomediastinum will result in pain and severe dyspnea, while an air embolism will interfere with blood flow to vital organs, including the central nervous system. An air embolism can happen in a dive as shallow as 6 feet and is a leading cause of death in divers. Signs and symptoms include mottled patches on the skin, hemoptysis, and or a complaint of muscle, joint, and or abdominal pain. They may also present with dyspnea, dysphagia or difficulty speaking, and visual disturbances. Paralysis, coma, irregular pulse, and cardiac arrest can also happen. Decompression sickness is a potentially life-threatening condition that occurs when dissolved gases, especially nitrogen, form bubbles in the body's tissues and bloodstream. These bubbles can cause an air embolism in the circulation, and they can compress or stretch blood vessels and nerves. Decompression sickness, more commonly referred to as the bends, results from a rapid ascent, prolonged dive at too deep of a depth, or multiple dives within a short period of time. The most common symptom of decompression sickness is severe abdominal and or joint pain that causes the patient to double over or bend. Patients may also complain of itchy skin or rash, fatigue, dizziness or vertigo, and ringing in the ears. Decompression sickness symptoms may happen suddenly or may be delayed by several hours. Treatment of diving emergencies includes supporting airway, breathing, and circulation. This includes suctioning if necessary and administration of supplemental oxygen to maintain a minimum saturation of 94%. Obtaining an accurate dive history, including depth, times, ascent rates, surface intervals, and breathing gases for the 48-hour period before the incident can be extremely helpful. During transport, keep the patient supine or consider placing the patient in a left lateral recumbent position with the head lower than the rest of the body. This can be accomplished by placing the patient on a backboard and elevating the feet of the backboard. Patients who suffer a diving emergency need recompression in a hyperbaric chamber, even if symptoms appear resolved. The Divers Alert Network, or DAN, can provide around-the-clock recommendations for treatment and where to transport patients who have experienced a diving emergency. Much like contacting the poison control for suspected poisonings, it's recommended to contact the Divers Alert Network for all suspected underwater dive emergencies. Now let's switch our focus to emergencies that can happen at high elevations. At higher altitudes, atmospheric pressure becomes decreased, which makes less oxygen available to the body. Some EMS techs consider high altitude greater than 5,000 feet, but we generally don't see problems until approximately 8,000 feet. Travel to elevations above 8,000 feet by unacclimatized individuals can lead to development of one or more forms of acute altitude illness, including acute mountain sickness, high altitude cerebral edema, and high altitude pulmonary edema. Patients with pre-existing diseases can increase acute mountain sickness risk by magnifying the effects of hypoxia. Acute mountain sickness is an illness that can affect climbers, hikers, skiers, or travelers at high altitudes, usually above 8,000 feet. Acute mountain sickness is caused by decreased air pressure and lower oxygen levels at high altitudes. Individuals at risk for acute mountain sickness include those living at sea level that travel to a higher altitude, those with medical problems including heart, nervous system, or lungs, and those with anemia. Individuals with a prior history of acute mountain sickness are also at risk to experience it again. Symptoms can include headache, fatigue, lightheadedness or dizziness, loss of appetite, nausea, difficulty sleeping, dyspnea with exertion, and facial edema. Symptoms usually begin a few hours after arriving at a high altitude, but can take up to 24 hours to appear. The image here illustrates what facial edema can look like. These pictures are both the same woman. On the left, she's seen at normal altitude, while the picture on the right is an image of her while hiking at 13,500 feet. Emergency medical care for these patients is to provide supplemental oxygen and descend to a lower altitude. The Wilderness Medical Society recommends administration of supplemental oxygen to maintain an SpO2 of at least 90%. High-altitude cerebral edema is a severe and potentially life-threatening form of acute mountain sickness. Cerebral edema is a collection of fluid in the brain tissue and is more common at altitudes above 12 to 13,000 feet. Cerebral edema can cause the brain tissue to herniate downward, causing the brainstem to become compressed at the base of the skull. This affects vital body functions such as breathing and blood pressure. Signs and symptoms of high-altitude cerebral edema include ataxia or loss of muscle coordination or control, changes in mental status up to and including seizure and coma, severe headache, fatigue, and apathy. Basic care for high-altitude cerebral edema includes administration of supplemental oxygen and descent to a lower altitude. Ibuprofen 600 milligrams orally every 8 hours may also be considered for severe headache. High-altitude pulmonary edema usually occurs at altitudes greater than 8,000 feet, but can happen at altitudes as low as 6,500 feet. Victims will develop non-cardiogenic pulmonary edema secondary to hypoxia. Initial patient complaints may include dyspnea with exertion, non-productive cough, fatigue, weakness, and a gurgling sensation in the chest. As this progresses, the victim may exhibit dyspnea with mild exertion or while at rest, cyanosis, and a productive cough with hemoptysis. Physical exam may reveal central cyanosis, rales and wheezes, and tachycardia. If able, the patient needs to be brought to a lower altitude. Supplemental oxygen should be administered to a minimum SpO2 of 90%. Patients who do not improve with supplemental oxygen administration may benefit from CPAP. Sicker patients may need ventilatory assistance with a bag mask device. While oxygen and descent to a lower altitude are mainstays of treatment for high-altitude emergencies, advanced providers may have access to additional medications that can help the patient. Based on updated research, the Wilderness Medical Society's 2024 Acute Altitude Illness Guidelines recommend the use of dexamethasone for the treatment of acute mountain sickness at a dose of 4 milligrams every 6 hours and for the management of high-altitude cerebral edema at an initial dose of 8 milligrams with administration of an additional 4 milligrams every 6 hours. When treating a patient with high-altitude pulmonary edema, these guidelines recommend the administration of 30 milligrams of nifedipine extended release orally every 12 hours or 20 milligrams every 8 hours. High-altitude pulmonary edema is not a fluid overload problem, so the use of nitrates and diuretics is contraindicated. Another option for on-site care when evacuation to a lower altitude is not possible is the use of a portable hyperbaric chamber. As we see in the image here, the patient is placed in a bag and air is pumped in under pressure by an electric or foot pump. The resulting pressure increase can be the equivalent of descending anywhere from several hundred to several thousand feet. On this page, we see the resources that were used in addition to your textbook to create this learning module. A great deal of information is available on drowning, diving, and altitude emergencies at these various sites. This brings us to the end of the presentation. Here we see the learning objectives for this module. Can you demonstrate each of these objectives? If not, consider going back to review any content that you struggled with. Thank you for watching this learning module.